Polypharmacy historically has been the most requested lecture by attendees and the highest rated, primarily because we all kind of deal with this issue, and we all can really share with each other some of the difficulties that we deal with within this area. When I was back working for the military, I was embedded within a family medicine clinic. And so I would see a number of different things. You know, I had my bariatric surgery clinic that was every other week. And then I had, you know, my anticoagulation clinic that I ran every Wednesday morning. And, but when I was not in there towards the end of my tenure, I was in a family medicine clinic, and I would see a number of different things, diabetes patients, you know, like I joked yesterday, A1C, like the age. And polypharmacy was something that I would get consulted on quite a bit for evaluation, and just to try to see, okay, what's going on here at this, you know, at this time? How can we potentially help this patient's profile? You know, just sheer numbers sometimes. So when you guys think polypharmacy, what are some of the things that come to your mind when you hear that term in practice? I'm curious. 40 meds. So just sheer number, right? What types of meds do you think participate here? Is it any med? Is it some more than others? Okay. It comes from everywhere, right? So prescription, over the counter, and then, and what's that?
Too many meds.
Too many meds, right? Herbal therapies. Yeah, exactly. What else? What contributes to it? Multiple specialties, right? So they're going to multiple specialties with good intentions. You know, one thing I want to say this morning is, you know, no good deed goes unpunished. I mean, a lot of times we're trying to do the right thing, but then it just stacks and stacks and stacks. And, you know, communication between providers and patients, and our patients letting us know a number of different things that they're doing outside of, you know, just seeing us. What else? Self-medicating. No way. People do that? Oh, yeah. I mean, how do they self-medicate? What do they use? Alcohol. Yeah. It's a big self-medication for sure. I'm going to talk some about that here in just a few minutes. What else? Other people, what'd you say? Oh, borrowing. Yeah, like, hey, do you have any amoxicillin? I'm fresh out. And I'm like, no, but I've got Cipro. All right, even better, right? So medicine cabinets, right? So medicine cabinets are just full of, you know, unused medication courses, and we laugh about it right here. You know, we laugh, but in practice, it's no big deal to some of these folks. It's like them sharing McCormick spices, right? I do love McCormick, man. They're everywhere. But you know, when you think about that, it's getting into the mindset of, oh, I'm sorry, Andy. Getting into the mindset of, you know, what does the patient feel is a drug? First of all, you know, how do they define a drug versus something that isn't a drug? And it's interesting to, you brought up OTCs. I mean, we'll talk about that and kind of how patients feel about OTCs. But yeah, a lot of these things really contribute to ultimately polypharmacy. And so a lot of the consults I get are just honestly a shock factor. Like one of the providers would just look at the patient's profile like, I can't believe this is really happening, because it's probably not. And you know, why do we worry about polypharmacy? What are some of the potential complications of this? Drug interactions, right? We got a whole thing on drug interactions we're going to do after the polypharmacy. Yeah, drug interactions. So the whole idea is drug interactions And drug interactions can manifest a lot of different ways. Sometimes it's a true drug-drug interaction, and we'll talk about how that can manifest here in just a little bit. And then also, it can just be additive effects, okay? Multiple prescribers was mentioned earlier. So my wife is a pharmacist. She works in the community, and she texted me one time. She's like, "You're not going to believe this." And I said, "Oh, I will, trust me." She's like, "Oh no, you're really not going to believe this one." I was like, "Okay, try me out." Now, when she says that, I know it's good, right? You know it's good. And she had talked with a patient, and after discussing with them what was going on, she really figured out, and she asked 5 different ways, interrogate. The patient was taking Xarelto and Coumadin at the same time. And you think, how in the world does that happen? But confusion, 2 drugs that, yes, they're anticoagulants, but, they really, you wouldn't expect people to take them together, but they do. Rarely, they shouldn't. But just things like that happen so I think you're surprised by some of the things that can happen in the right patient scenario. So we're going to talk about a lot of these reasons. Definitely share stories if one comes to your mind and you're like, you're not going to believe, oh, I remember I had a case like X. Hey, we're all here to share and learn. So this is good. And I'll talk a lot about my mother-in-law here in just a second. So I do love my mother-in-law, but she asked me. So I told you I'm going to show you what she gave me. So anyway, it'll be good. All right. Very good. You guys came back, so that's a good sign. All right. So no relevant disclosures. All right. So we're going to recognize factors that lead to polypharmacy in the elderly. So what are the things that lead to this happening? How does this happen? Right. Number 2, we're going to define what inappropriate means. Now, this can be somewhat controversial. I know some of y'all, we're going to have some differing opinions on some of these, but these are what the governing bodies have. And we can talk about some of the problems that we have. I mentioned one yesterday. We all know hypnotics are not great. Okay. But what do we do with that? That's a different question. Describe tools to screen patients for polypharmacy. So what can we do to screen to kind of get an idea of evaluation for this? These aren't perfect, but they are tools. And then we're going to describe the best practices for limiting adverse effects in what I would term necessary medications. So let's start with a case. So this is a 74-year-old female. She reports to her Coumadin clinic appointment, okay? And I remember this case. The reason I use it is I can remember it just like it was yesterday. Because I was sitting at my desk, I was getting ready for the morning. Normally I would see patients between 7:30 and about 11:30. And basically what happens is I had really good support at this clinic. We did point of care testing. So they would come in, they would get point of care testing. I would have them fill out a form, and then they would show, then we get their INR, we'd make an adjustment if needed. And I was getting ready for my first patient, and she kind of just walks through the door, no appointment, no nothing. I'm kind of like, "Can I help you?" And she looked so confused. She didn't know where she was, what was going on. And basically what she told me was that she got discharged from the hospital at 8:30 the night before, right? So first of all, what do you think about discharging patients at 8:30 p.m. after they've been in the hospital for a while, right? And then the next morning, they told her she needed to come in and get her INR drawn, right? So some of it's just practicality of, this is a 74. I mean, I know I'm 46 years old. I go to bed earlier and earlier. It's just, I don't know why, but it just is. And so after a patient's been in the hospital for that long, and then now they didn't get any sleep probably in the hospital, and now they're going home and coming right back, she's confused. She looked very confused and out of it. And so she was admitted for AFib with RVR. That's why she was admitted to the hospital previously. The night, got discharged the night before. So she pulls out 2 different pill boxes, 2 different pill planners. And basically she's like, I don't know what to do with this. Y'all ever had that? Patients pull them out and they don't know what to do. And so I start looking I'm like, I really, and of course, y'all know this primary care, you don't have time to that's the problem with polypharmacy, is to do it right. It takes hours to really sort through everything. I will say when you do it, that's why they send them to me as the pharmacist in the clinic, because I would just set aside like a big appointment time to do it when our prescribers just didn't have time to do it. So, but it was some of the greatest, I would say, in my career, interventions I've made was straightening a lot of these things out. So I start looking in there, and I look in her inpatient record, and she was supposed to stop her diltiazem and begin her metoprolol, which she was discharged on. But when I looked into the planners, there was still Toprol XL and diltiazem just all there. And so that was going to be a risk for combination duplicate therapy, both rate controlling agents, where then she's going to get hypotensive, bradycardic, could be falling, you never know. So this is an example of a lot of factors contributing to her polypharmacy. So we're going to hit a number of these, but just think about this case. You've probably had cases that are somewhat similar, maybe not exactly, but a lot of these factors we're going to talk about, I guarantee you've seen them in your practice. So at the top here, that's my knee, okay? So I was sitting enjoying July 4th, and grandma comes up. We call her grandma, it's my mother-in-law. And she's like, well, do you mind looking over my meds? And I was like, sure, why not, man? It's July 4th, I'm relaxed, this will be fun. And I said, but do you mind if I take a picture of your meds to use in my talk on polypharmacy? Because I knew what was coming. And she's like, yeah, sure. So when you guys look at this, what do you see? What kind of stands out, good and bad? Doesn't matter. I just want to hear what y'all think. I think you can teach through pictures. There's a lot. Yeah. So I think let's count them here. So you got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So we got 20. All right. She hit 20. Yeah, that's a lot. Yeah. There you go. So that was one thing, her daughter's a pharmacist, I'm a pharmacist, like, please try to use the same pharmacy. And so we harp on that. So I actually gave her some props, and I said, well, I'm very proud of you because it looks like everything is from the same Walgreens. And she said, yes, I go to the same Walgreens all the time. I know y'all beat me on that. Talk to me about that. But yeah, that can be problematic, right? Because patients think that we all are linked. They think like CVS is linked to Walgreens, is linked to the VA, that like all the drug interaction screenings happen simultaneously. And I'm like, oh, no. Cost of drugs, right? It's a big debate right now. A lot of things going on. I don't know if y'all heard, y'all watch Shark Tank, right? So Mark Cuban, he's got this thing called cost plus drugs. He's had it for a year now. But essentially he's really he's building a plant out in Texas. But the idea is that he's trying to negotiate with a lot of these generic manufacturers so that, the cost of drugs cost plus, meaning that that these astronomical fees on some of these. Because right now the pricing system is really complicated. It's broken. So, people will shop around and they'll go to Costco. By the way, you can get your prescriptions at Costco even if you're not a member, because by law, if you have a pharmacy, you have to fill somebody's prescription even though they're not a member. So Costco is actually a pretty decent place at times. But it's funny because one of the financial guys in the Southeast, he has this radio show and he's always talking about, go to Costco for, everything, including your drugs. But the problem is if you don't go to the same place, then that can lead to a drug interaction too. So it sounds like you're saving money, but if you miss if one pharmacy they're getting Coumadin and the other they're getting Xarelto, and they're taking them together and nobody's really assessing that could be problematic. Okay, what else? Yeah, kind of look the same. So it's like, a mistake could really happen pretty easily. She takes the wrong one. Yeah, very true. Yeah, you guys are hitting a lot of the good things. Anything else? So you can't see it, but this one is Vasipa, icosapent for cholesterol. So remember yesterday I talked about size of drugs and, some of these drugs having data, some of them not. This one actually does have a little bit of data for morbidity and mortality. What about this thing right here? What does that look like probably? Could be Tylenol, could be herbal, could be a vitamin. It's a vitamin. It's a vitamin. I can't remember which one. It's like vitamin fill in the blank, okay? So like this is a vitamin and this is a vitamin. She takes a couple of vitamins. She's got a nasal spray here. She's got a number of things. I won't get into the actual drugs that she's got, but I can tell you, guess what I found when I started digging? Diltiazem and metoprolol. It was like a flashback to the case I had at my own job. And I was like, why are you on both of these? And she started talking. She has new onset AFib. And basically it sounds like two prescribers were not talking. And so she was having what sounded like some bradycardia a little bit. So we got her straightened out. But yeah, I mean, so this is just a taste of what can happen. Prescription, non-prescription, other dosage forms, nasal sprays, eye drops, a little bit of everything. And I was like, how do you know to take when and where and how? And she does have a pill planner she uses by the week. So some of them are by the week, some of them by the month. Hers is by the week. She showed it to me. It looked very reasonable. It was big, pretty easy to see. So yeah, so that's my mother-in-law in a nutshell. So deal with this. Y'all deal with this with family all the time? Yeah. Yeah. What color is that one? And see, that one's trouble, right? Because colors change. We get sent a different manufacturer, color changes, right? And they're like, is this the right one? And I had a guy one time, he had a candy dish, and that was what he used. He just put them all in one big dish, and he knew what color they were. Like Halloween or something. But anyway, all right, very cool. All right, so let's define it. Well, we're going to try. So there's a wide range of definitions, but there's no consensus definition. Generally, it's defined as administration of more medications than clinically indicated, representing unnecessary drug use. A lot of organizations have used this 4 to 5 medications. Now, this is the time of the presentation when you can laugh. It's okay, right? 4 to 5. Now, why is that such a low number? Because it is, right? Let's take a disease. What did we talk about yesterday? Diabetes, right? That's 5 meds, right there. Metformin, SGLT2, maybe some insulin, right? Don't forget about controlling their blood pressure, right? So 4 to 5 meds, I mean, we get to that really, really quickly. So it's an arbitrary definition, but it's a starting place. Like I said, it's where we start. It's not necessarily where we finish. There are a lot of kinetic changes in the elderly. So PKPD is a big thing I teach at Georgia. When we're talking through and starting an elderly patient on a drug, thinking about how drug studies are done, patients are living longer. And we'll talk about that here in a second, but a lot of these drugs are cleared by your liver. And hepatic blood flow drops somewhere by about 40% over time. Half of elderly have some form of chronic kidney disease. And so right away, the way these drugs are eliminated, whether it's a hepatically cleared drug or a renally cleared drug, it's not getting cleared near as well as it used to when they were in their 20s and 30s and 40s. Heart failure patients can further exacerbate these decreases. So as patients have heart failure exacerbations or their ejection fraction gets worse, they're not clearing it, they're not pumping it out, it's not getting cleared like it used to as well. Certain drugs undergo first pass clearance. So warfarin, benzos, opiates, all of these. And so that clearance goes down. Those drugs accumulate. It gets pretty ugly, right? Like, for example, Valium's half-life is somewhere around 120 hours, even if you have no issues. I took Valium one time. I had a back spasm. Y'all ever taken Valium? You don't have to admit it, but I did. And because, most muscle relaxers, let's be honest, do they really relax muscles? No, they just make you sleepy, okay? Like I took Flexeril one time. I don't know if it relaxes muscles or not, but 14 hours later, I woke up and I didn't care. I was just like, I'm drowsy. So benzos, especially the longer acting ones, in the elderly can really take a long time to get out. So that's going to increase their risk for confusion, delirium, and ultimately falling from that. Protein binding. And then kind of some common things, malnutrition is very common in the elderly. Depending on, like right now, my mother-in-law's best friend is caring for her mom. And I saw her the other day compared to when I saw her a year ago, and she just looked so malnourished. She had been rehabilitating after a surgery and just has not gotten back to where she was with her nutrition. Dentures. When people get dentures and they get admitted to the hospital and they're not eating any of their meal. Well, they don't have their dentures, right? So do they fit appropriately? Food preparation differences, right? So I got to tell this story. It has nothing to do with polypharmacy, but my daughter's now at Charleston Southern for college, and she's like, Dad, I love it here. I love it here. The only thing I don't like is the cafeteria. It's not mama's cooking. And so what's interesting is she's not put on the freshman 15 because she's just like eating less than she was. I was like, well, you have to eat healthy though. What happens to patients as they get older? They don't feel like cooking as much. They don't eat as healthy. They may get admitted to a rehab facility or a nursing home where they don't like the food as much. And so those things can definitely change as well. Dietary restrictions. And then substance abuse. So we mentioned alcohol earlier. Up to 10% of elderly use significant alcohol. And you can define that by the standard definitions. But there's a lot of it that's there. And COVID actually has made this somewhat worse in the sense that people were bottled up. Depression, anxiety increased, especially in, for long periods of time. There were some people I know in New York that they didn't come out of their apartment for months and months and months. And I can't imagine how depressing that would be. And so we do see these. And now, you say, well, they didn't get out. How'd they get their alcohol? Uber, right? We got Uber Eats and DoorDash, and anything can be delivered, even a swimming pool. No, I'm just kidding. But anything can be delivered to your door now, just about. So when you look at the elderly population growth, nearly 42 million, so 13% of the total population. And what's interesting is who's going to take care of the elderly population? Who's going to take care of us? Because the population replacement's going down for the first time. We're below 2. And so as we continue to grow and get better health and live longer, cancer deaths are down significantly from a decade ago due to earlier detection, better treatment. And so this is a major, major issue, just caring for the elderly, in the sense that the people caring, our population replacement's not what it has been in previous decades. And at your 65th birthday, you have a median life expectancy of 18 to 20 years. So especially for women, you guys live longer. Told my wife that you're probably going to be here, and I'm going to go before you. So we have I call it the love paper with all our passwords and accounts, and in case something happens to me, because it could happen. And so It's interesting when you talk to pharmacy students, man, they think this is like ancient, like this has never happened to me, you know, and then all of a sudden you wake up and you're 40. You're like, whoa, what's going on right now? Or you're 50 or you're 60. But even if you're here, you probably got 18 to 20 years left, even at 65. Okay. Get out in the sunshine, walk around. I mean, it's not out of the realm of possibility for sure. And that's a good thing. Over a third of elderly receive 90% of their income from Social Security. So how does that contribute? Tell me some different ways y'all have seen that in your practice. How does finances affect drug therapy? What do they do? Pick and choose, which brings up the topic. How do they pick and choose? It's a good question. What drugs do they pick? What do we want them to do? What we want them to pick versus what they pick? Could they be the same? No. What do they like? All right. What do they pick? How do they choose? Whatever's cheapest. Stretch it out. Like yoga, stretch it out. Right. So that's what I've seen a lot is they'll say, okay, you know what? I don't need this Lipitor every day. Maybe if I take it 3 times a week, Monday, Wednesday, Friday. Inhalers. Only when I need it. So like if they're on a steroid, chronic inhaler, take it once a day instead of twice a day, or take it every other day versus every day. Yeah, I think that is underappreciated. Yeah. I've often wanted to do that study, is really like talk to patients, tell me what you're really doing, yeah, things that treat pain, they're going to pay for because they don't want to be in pain, right? The diseases that we know can kill them, but they don't have any symptoms day to day. Those are the ones I worry about non-adherence the most. Blood pressure, diabetes, at least there's a number that they're checking that makes, oh man, I'm really high today. I'll take it. So my mother-in-law is, fortunately she does fine, but she's a retired school teacher. And so she has a pension from the state. And so that, along with her Social Security, is very, very helpful. But then, recently she got diagnosed with AFib. It was interesting. So my mother-in-law and father-in-law both got diagnosed with the AFib within like 2 months of each other. And they both got put on Eliquis, and they were complaining to me about how much this cost. And I was like, I know. And they were explaining, how they were deciding what they were going to do. And I said, well, that's one drug you can't start and stop. I was like, because there's a big warning about stopping any of those anticoagulants due to a risk of acute stroke when you stop them abruptly. But yeah, the financial part is really, really difficult when Social Security is their only source. Nearly 7 in 10 adults above age 40 used at least one prescription in the last 30 days. I don't think that it is very shocking. 1 in 5 use at least 5 prescription medications. So one thing I would say too, in the United States compared to the rest of the world, that makes this worse, US is kind of the highest, is direct-to-consumer advertising. It's very high. Magazines, TV, streaming, you name it, even online, Google ads, Twitter, Facebook, it's kind of everywhere. 1 in 5 uses at least 5 prescription meds. So looking at those age groups, does that look about what y'all see in your practice? You think the most common meds? Age 40 to 59? One of my best friends, he is really struggling with depression right now. He was texting me. I was in the airport. He's a Chick-fil-A operator. You talk about a stressful job. Ooh, man, everybody loves Chick-fil-A, but man, they are busy. And he's even having trouble hiring people. And it's difficult in the food service industry. So we had some discussions about what he's doing about that. Excuse me, I got like one in my throat here. Cholesterol, diabetes agents, beta blockers as you get older, right? Those are the most common ones. More than 90% of non-institutionalized patients are on at least one med. But most who engage in the healthcare system get 6 to 8 meds, and that's about pretty consistent among the studies. And then you got these comorbid conditions like hypertension, diabetes, heart failure that, of course, require, I mean, look at heart failure. I mean, you get to 5 quick, right? ACEs, beta blockers, diuretics, now SGLT2s, right? You should be on one, right? We hadn't even talked about the aldosterone antagonist. That's 5 right there. Somebody's got severe heart failure, chronic heart failure. A lot of reasons for why they get up on the meds. Prevalence is high of those taking more than 5. A lot of factors, demographic, health factors, and access. Where do patients go to get their drug information? Like, how do they decide sometimes to take even an OTC or an herbal? Where do they go to get that? Google. What else? Friends? Friends. Even if they're not in healthcare? Right? That's what I always tell my mother-in-law. I'm like, now listen, do you want me working on your car? No, why would I ever do that? I'm like, exactly. But they go to their friends, all right? Their friends they eat breakfast with, lunch with, etc. Oh, I'm on this agent, right? You should try it. They don't go, oh, well, maybe I should check with my pharmacist, nurse practitioner, PA, physician to see if there's a drug interaction. Nah, man, that's too much work, right? But that's what happens, okay? So demographics, yeah. The internet is just full of information, bad and good. And so that's where they get a lot of this information when they're trying to decide what they're going to take. See here in the chat, I see y'all out in the Zoom land. Seductive commercials. Oh, they are. I mean, I was singing Ozempic yesterday to y'all, right? They're really good. I mean, they spend marketing dollars I mean, they have ad agencies, y'all. I mean, it is very crafted in the message. I can promise you that. So, and then access, once they get to a certain age, they have Medicare. And so with Medicare, that grants them access that sometimes they may have not done previously, but they get into that age where then they have it and then they go and get care and get seen. And I think for us too, is it hard to not give somebody something? It's kind of intuitive, right? Like antibiotics especially, it's like you feel like they feel like you should give them something, but sometimes the right answer is not to add on. It's to take stuff away. Okay. Let's see here. Yeah, don't forget OTC. Oh man, next time you're in name your pharmacy, grocery store, whatever, go look at the OTC sections. So just for fun over Christmas, I wasn't, my family was ill. I didn't really want what they had. So I left and I got it anyway later. But I was like, I'm gonna go. So my son needed some Delsum cough medicine. He was hacking his brains out. Okay. So I was like, you know what? I'm going to do an experiment here. So I went and stood in the Walmart OTC section. I don't work at Walmart. I used to. Okay. I was like, I'm just going to watch and see what people do and interview them. Yeah, of course, y'all know I would do something like that. So, because it's beautiful, right? Because I wasn't working and, I just wanted to see what they do. So I'd watch them. They'd walk up. And y'all, can you imagine? You guys all know about drug therapy. These people know hardly anything. And all of a sudden, they walk up to this huge cough and cold aisle. How do they pick? I mean, have you thought about, how do they decide? So I wanted to know. So I interviewed him. Oh, yeah, I had a guy came up. he's all congested. I was like, how do you decide what to do? He's like, oh man, I love Afrin nasal spray. I was like, really? And I said, well, tell me. And he's like, this stuff works really well. I use it all the time. I was like, for how long? You know, I'm just acting stupid. Man, oh, really? Okay. How long? And he's like, oh, yeah, I've used it for days and days on, you know, which is wrong, right? You're only supposed to use it for 3 days and then stop it. I was like, do you ever feel like you're dependent upon it? And he's like, yeah, it does seem like it comes back a lot. No one's ever talked to this guy, right? Come to find out, he's on all sorts of neurologic meds and hypertension meds. And I mean, it's scary. So I told him I was a pharmacist at the end. I just didn't work there. And he's like, oh. And so I tried to explain, because he picked up the Afrin, and then he picked up some other product that had a decongestant in it too. I was like, well, don't use those together. Pick one or the other. He's like, well, you could tell like he didn't really care what I had to say. I'm going to do this. Okay. So that's how they end up in the ER. I mean, I think he believed I was a pharmacist. I told him I didn't have my license with me. Right. So then another lady comes up. She's probably in her 30s. And I just had a conversation with her. I'm just like, how do you decide what to get? She's like, I have no idea. I just kind of pick something. That's what's really going on out there. Like afterwards, I went home, told my wife, I'm like, I don't know. Like, I don't know what to do now. Like, I think we need to like have police in the OTC section. Pharmacist police. Excuse me. What are you doing there? Oh, I'm just, you know, y'all remember that commercial Reebok? It was called Office Linebacker. So when people, it was a hilarious commercial, but basically it was like corporate. It was like The Office, and they hired this guy to be, he's a former NFL linebacker. And so productivity was down at the office. So they got an office linebacker. So if people were using the copier too much, office linebacker would tackle them. Right. Or, you know, and they're like, productivity's up 80% this quarter, because people didn't want to get hit by the office linebacker. But anyway, you need a OTC pharmacist. I pitched the idea to Walmart years ago. And I told them, I said, look, if you put somebody out there, people will talk to them. They will talk to them. And I said, you will separate yourself from every other pharmacy. And I said, when you do recommend a product, you can recommend a generic that will save them money and your margin will be higher. So it's a win-win. I didn't do it. They didn't do it. I don't know why, but they didn't do it. I didn't ask. But anyway, so when you go to the OTC section next time, man, like hang out, man. It's fascinating. It really is. So I'd give you all those scenarios. Now take an elderly person in the OTC section. Are they asking any questions? Are they just I mean, it's freely available. What do patients feel about OTC meds? That they're safe. They're not like prescription drugs at all, right? But I know this, some of our most harmful drugs are OTC. Like what? Ibuprofen. Told a story about my Uber driver, right? I mean, you can make ibuprofen very toxic. Aspirin, depending on how much you take. Drug interactions. Yeah, there's a lot of them out there. Elderly have more time. They're retired. They go out to Walmart, Kroger, Publix all the time. Hey, let me swing through here. Let me check this out. Right? And the ads on the boxes are very enticing. I mean, they're very beautiful, colorful boxes. Right? 15 billion spent on herbal products every year. It's a lot. It's a lot of money. Y'all heard of this product? Old CBD, you know me, right? Go look at signs, advertising. There's CBD stores everywhere. Are they trained to screen people for drug interactions? No way, right? So CBD does have some data. There's a lot of product options. Oh man, you got oils, gummies, lotions, capsules. More. I mean, it's out there. And guys, this is not like fly by night CBD oil, you know, just hanging out at these like weird stores. This is everywhere. I walked in Publix. So I live in Hardyville, South Carolina, and Hardyville is right beside Bluffton. I don't know if y'all know where Bluffton is. And Bluffton is right beside Hilton Head. Okay. So Bluffton is one of the fastest growing cities in the Southeast US because there's a lot of people that retire.
Yeah, but you don't want to hear it. So,
you know, decent prices on some things, decent land prices. And so a lot of people are moving there, especially elderly. And so there's a Publix over there about 10 minutes from my house, and they've got 2 huge CBD boxes over there that anybody can grab. And I'm just thinking, man, all these retired elderly are grabbing some of this CBD stuff. So essentially binds to the cannabinoid receptor, and it does have some limited data for pain, inflammation, right? Areas, elderly, osteoarthritis, et cetera, that they could easily take on. There is one FDA approved product for epilepsy, so it does have some anticonvulsant properties. It's a substrate of cytochrome P450, primarily 3A4 and 2C19, but then also a couple of other. These are not really that clinically significant because not a lot of drugs go through 2C8, especially 2C9. That's a little different. Coumadin goes through there, but mainly substrates. So these are just some of the different dosage forms here. So hang with me. I got cases coming, y'all. These are awesome cases. I can't wait for y'all to see them. So CBD, y'all seen a lot of CBD out there? Are patients telling you they're on it? No. Some? All the time? No? You have to ask. Is there a dosage form they like? They use kind of all of them? I've seen them all. Okay. Y'all, no, I'm glad. Can I interrupt for just a second? Hairdressers and barbers, powerful people. And I'm not kidding. My wife, I think if her hairdresser called her at 2 a.m., she would go help her. Not kidding. Why? I mean, I've had a bad haircut before. It ruins you, man. And I trust it. So it's interesting, real quick, before you give your story. There was a publication in New England Journal of Medicine that was a hypertension trial that pharmacists ran. And the way they recruited people was a barbershop. And it was incredibly successful because the barbershop they're like, hey, these are trustworthy people. There's a blood pressure trial. You should really check that out. I mean, it was brilliant and it worked really well. But anyway, go ahead. So hairdresser.
Container of lotion for pain.
Yeah.
On and on and on about it. So, you know, and at that point, we were starting to kind of monitor her monies and help her a little bit. We couldn't figure out what in the world she would have spent, you know, like $90 at hairdresser that day. And
wow.
To find out, this bar was $65
for a little jar of CBD.
Yes. So it had some name on it. I don't know, P, and that's how she refers to it. It's my lotion that starts with a P. So, you know, she's got some dementia. So I finally said, Mom, do you know what you're using? You know, this has got a little CBD in it. She said, no, it doesn't. Jane wouldn't give me such a thing. But, you know,
yeah.
It was really kind of a funny little family story for a while. But
yeah. But you bring up something very excellent, and that is our patients. There's some people in their lives that they really trust, and that trust extrapolates to healthcare, even though it should. I mean, in our minds, we know like that shouldn't happen, but it does. It does. So we got to take advantage of that in a good way. But yeah, you want to? Oh, really? I'm getting cold up here, so I'm putting my jacket on. Hairdressers providing therapy? Yeah. Right. Oh, yeah. Absolutely. Barbers and hairdressers, man. Oh, yeah. Very good. I didn't even think about that. Yeah. Still magnolias for sure. Excellent. Yeah. CBD, man. It's everywhere. Your dog? Chicken flavored CBD? Oh, man. Oh, I'm sure they do. No, I mean, the pet business is massive. That's another thing people do, by the way, is they order antibiotics online from other places that aren't verified, et cetera. And I'm not talking about just across the border, but just like these, now I see commercials for, I don't know what this drug is. Looks like for erectile dysfunction or something. Roman. Have y'all seen this commercial? It is everywhere. I'm like, what is this? Oh yeah, it's pretty, it's everywhere. But yeah, the pet, yeah, people were back in the COVID. My partner at USC, he found that people were ordering fish antibiotics, like antibiotics that you use for your fish, and they were using them for themselves. So yeah, I'm not kidding, Charlene. I'm not making it up. I wouldn't lie up here. So yeah, there's a lot of different ways people are getting into some of these things. So drug interaction concerns, because this is a 3A4 substrate, and a lot of drugs go through 3A4. Any drug that inhibits 3A4 could cause, either in this case, decreased concentrations of CBD, or in this case, increased concentrations of CBD and toxicity. Okay. And that can be manifested a lot of dizziness, somnolence, insomnia, some sleep disturbances. So we'll have a CBD case in a little bit. There are a lot of geriatric syndromes that can cause negative outcomes here. Things that are just unfortunately part of getting older. Urinary incontinence, cognitive impairment. We're dealing with this with my mother-in-law actually right now. She doesn't seem to be remembering anything we're telling her. So we're wondering if some of the cognitive decline is starting to happen. And then loss of balance leading to falls or fractures. So all of these are concerning. Poor adherence. So what is the magic number for that patient? I think I talked a little bit about that yesterday, is like how many drugs does it take before somebody decides, okay, I'm done. I've had that case a lot where patients just decide I'm done taking, I don't want to take anything anymore. I'm just sick of taking drugs. So that's going to lead to poor adherence. So it can be, how do you define adherence? I think we've already talked about this, but what are some examples of non-adherence? Besides not taking the drug, but what else could it be? Inappropriately, right. So kind of getting back to what we were talking about, skipping days, skipping doses. Right. It's any way that it's not prescribed. So, I mentioned the Pradaxa case, yesterday, where somebody takes their morning dose, but not their evening dose, which can be really, really bad in that case, because she was having TIA symptoms in the morning. And really the question comes down to, why are they doing that? Sometimes it's probably the most difficult thing in my career was probably 15 years ago. I watched a 31-year-old young man die from HIV complications. He died from pneumocystis pneumonia. And come to find out later, essentially what was happening was his mother was essentially controlling all of his medications. And she was so frightened about drug side effects that she halved all of his HIV doses, all of his drugs. And so when he presented, his of course, his CD4 count was so low that's why he got the opportunistic infection and he died. So that's that's not polypharmacy in the sense, but that sort of mentality of being fearful of side effects or being addicted to a drug, don't want to be on this drug the rest of my life. Those things can trigger non-adherence, not just not taking it. Like I would like that, that obviously led to resistance for him. So yeah, these are just some of the outcomes. Yeah, we talked about that. So how do we quantify this risk? Well, your chance of having an adverse drug event goes up pretty quickly. So with 2 meds, it's only about 15%. Once you get to 5 meds, it's a coin flip. You're going to have some side effect listed in the package insert. I mean, it just kind of makes sense from a number standpoint. It's like roulette. I mean, eventually your red, black, what, I don't play roulette, but anyway, I just know it's 2 colors. All right. But risk increases to nearly 80% once you get to 7 meds. And so talk to your patients about them, if they seem to be non-adherent, they probably are. And it could be side effects of a drug is a primary reason, along with cost, why people won't take something. Why do men not take beta blockers? Yep. They want to be able to have normal sexual activity, and they are worried about that. So it's just things like that, things they've read on the internet, right? And as pharmacists and pharmacies, we don't do this intentionally, but man, when we hand a patient that big patient leaflet, that's got 800 side effects, all of which are listed because they have to be, man, that's scary, right? Somebody reads that, they're like, I'm not doing this. This is insane. Okay. Nearly 1 in 5 hospital admissions are due to an adverse event. The rate increases to about 33% in patients that are 75 years and older because they're more sensitive to drug therapy, especially newer drugs. When you see, start drug at this dose, a lot of that didn't include patients that are 75 years or older, right? And so even starting lower, I think, is very reasonable depending on what the indication of the drug is, because you never know how they're going to respond. And then while in the hospital, a number of elderly patients experience an adverse event. I've seen a number of these different occurrences. I remember a lady, we gave her Keppra, first time she's ever had Keppra. I love Keppra, great drug, works well, doesn't have the drug interactions that Dilantin and carbamazepine. But man, they put her on a normal dose. She's like 85 years old. And I could hear her snoring from the other side of the ICU. She would just, and I was like, man, is she breathing over there? I mean, it looked like she was on an opiate. I mean, and she slept for like 14 hours on 1 dose of Keppra. Okay. So they're just more susceptible to some of these adverse effects. Do guidelines contribute to polypharmacy? What do y'all think? Man, what happens if you don't meet the guidelines? You feel bad as a prescriber, right? You're like, man, I do want to decrease their morbidity and mortality. I do, right? But how many guidelines are out there? How many disease states are out there? They overlap, right? I did a talk with a geriatrician from, he's a faculty at Florida State, man. He's got this great talk on guideline-induced polypharmacy. And many times it's appropriate. I reviewed, one of my family medicine physicians came to me and goes, oh, I've got a good one for you. I was like, okay, send them my way. So I look at them, they're on 22 meds. Every one of them was supported by a guideline. Every single one of them. And I was like, I have bad news for you. I was like, every one of those are supported by a guideline. He's like, impossible. I was like, I'll prove it to you. So here's the drugs. Here's the citation for the guideline. He's like, man. So they had a lot of disease states, COPD, diabetes, hypertension, low thyroid. I mean, everything, right? So sometimes it is appropriate, but then we have to make the assessment of, okay, just like I talked about with the frail elderly yesterday and A1C control, and like at what point is keeping a 90-year-old on 80 milligrams of Lipitor appropriate, right? Because muscle weakness, muscle aches, fall. I mean, at some point, like they're 90, their genetics are pretty good. What are we really doing at this point? So like a frequent reassessment of that, I think, is important. And to be fair, not every age is a number. In my AFib clinic, I had an 80-year-old. I'll never forget this guy. He was healthier than I was. I'm convinced. He cut his grass. He cut his neighbor's grass. He walked all the time. I mean, he was in good shape. So age is a number. Keep that in mind. Like functionality, I think, is really important to consider as well. Okay. We're having a big discussion right now in my house because my daughter's graduating high school, and my other daughter graduated high school last year, and grandma took her on a trip, and they went to Manhattan. Okay. Well, y'all ever been to New York City? You got to walk around. Okay. And she does not like to walk. And so it was a miserable experience for my daughter. Okay. So I'm like, Grandma, okay, you can take my other daughter, but let's not go to New York. Let's go somewhere where we can like sit down and hang out. Okay. So every person is different as far as what they can tolerate. But guidelines, while well-intended in the elderly, can be tricky. So how do we decrease this? How do we get this how do we attack this? So first of all, you're participating in an educational activity. Congratulations. You didn't even know you were in my slide. Okay. So this is really important. Organizationally, polypharmacy clinics. These are starting to come about. I don't know if you're aware of them. Kaiser Permanente has a really nice one down in the Atlanta area, also in California. About 3 or 4 years ago, they consulted me because they knew I did some of this, and I helped them kind of walk through some of the potential obstacles they were thinking about would happen. But it's been very successful. There's even a journal now out there called Deprescribing, and just talks about deprescribing medications. Financially, incentive programs and regulatory interventions, we're not quite there yet, but we're getting there. So we'll talk about some different tools here. Which one of these have you heard of? I already know the answer, but just say it. Beers, man. That sounds so bad for a criteria, beers. Have a beer, okay? But yeah, beers criteria is one everybody's familiar with. Stop and start. I'll talk about those. But then the drugs guide, this one's kind of new. I'll put this one out there. So the drugs guide is simple. It was published in the Lancet 2021, okay, the British. But DRUGS right here. So D, discuss goals of care and what matters most to the patient. Shared decision making. Do you really want to take this drug? Here are the pros and cons. Look, you're 88. Do you really want to take this Zocor? Mike, no, I don't want to. Okay, all right. You're 85. Your A1C is 8. Do you want to take this glipizide? Probably not. Okay, so just discussions like that. Okay, review medications, use tools and frameworks. G, geriatric medicine approach. I love this. Frailty, cognitive impairment, limited life expectancy. Really having those discussions on the front end. And then S, stop the med. I know it's hard, but you do it. You stop the med. I'm telling y'all, when I was in the bariatric surgery clinic, that's what made that clinic. I mean, that's why people wanted to join my clinic, because we were the stop med clinic. Oh man, you've lost 50 pounds. Let's stop that med. Oh, we were stopping meds every day. It was great, right? Same thing here. Palliative geriatric practice, stopping meds. So these are good. I've got the reference here for the Scott program here, JAMA Internal Medicine back in 2015. Sex and gender considerations for polypharmacy. Women are more likely to be caregivers You guys are so caring. You really are. I didn't grow up with a sister. I have one brother. My wife has two brothers. She already knows she's going to be the caregiver for her mom. Even though she doesn't live in the same town as her mom, the two brothers do. So I've kind of pushed back on this. I'm telling her about this data I'm looking at. I'm like, no, your brothers are going to help because I'm going to be involved. And she's like, yeah, okay, easier said than done. I was like, oh, no, I can be very persistent. Okay. But who's advocating for the caregiver? If y'all run into that, sandwich generation, y'all have probably already dealt with it. You've got kids you're dealing with, and then you got your parents. Man, that's tough. My dad is 79. He's pretty healthy. I don't know how the guy is still alive. I love him. I'm a 46. I look just like him. He's 79. He eats horribly. I mean, gas station food, coffee, like with sugar, cream, like fried food. He's on 20 of simvastatin and like 8 milligrams of one of the sartans. I'm blanking on it right now. And that's pretty much it. His labs are good, his blood pressure. He might live for another 10 years, right? You just never know. My mom, unfortunately, she was an alcoholic. She died at age 50 from cirrhosis. So we're all dealing with different things, So it's like I've got both extremes within my parents. One that died very quickly and one that, I don't know what this is going to happen. He lives with, it's a long story, y'all. My family, we put the dis in dysfunctional, okay? But his first wife, who he divorced from, my dad, she never remarried. So 40 years later, now they're remarried again. Is that wild or what? It's like a Lifetime movie, Christmas movie, okay? And so they live together. So I'll call and she's kind of there with him. She's in good health and watching him. But anyway, but yeah, what about women? Who's caregiving for them? Who's watching their health? Who's making sure their colon cancer screening's up to date, right? Women use more prescribed and OTC meds. Why do you think that is? They do seek care. Yeah, they care about their health. All right, what else? I have some other theories. Yes. Yeah, it's on sale. Oh man, me and my wife had this discussion all the time about being on sale. But that actually gets to my point is women are marketed to more. Big time. Because, my wife has guilt every month. You know why? She's the one spending all the money in the house. But it's not because she's going out spending but she's the one that buys the kids' clothes, buys the food, goes grocery shopping, does these things. And it's like, she feels bad, but it's like, no, you're the one executing all the things we have to do. It's okay. Sometimes my wife, so we're kind of like, gender roles. Like she's the one that loves to go to Lowe's and Home Depot. Okay. She loves to paint, do things. Not me. I love to call somebody to do that. Okay. But sometimes I'll just be like, why don't you just go take a couple $100 to Lowe's and go buy something? Like you're driving me crazy. Like you feel like you're not the problem. It's just a busy time. Like we got 3 kids, one in college, one in private school. Marketed to. Guys are marketed to a lot. Women are more often prescribed psychoactive meds. I think that's because they're honest. I'm depressed. I'm anxious. I'm really struggling. That's why my friend who's a male at work, Chick-fil-A operator, I'm trying to be very supportive of him. Like, I'm so glad you're telling people about this. And then he told me yesterday, he said, you're right. He said, a female came up to me at work. She's another operator. She's like dealing with the exact same things I am. I'm like, yeah, it's being honest. It's been a hard 3 years, right? Men are more often to receive secondary prevention drugs. This is terrible. Women have heart attacks. and they die from them every day. Women receive lower overall doses. Makes no sense. More likely to be frail, more likely to discuss deprescribing than men. I think this is interesting. I think men just deprescribe. They just stop taking it. Women actually discuss it. It's true. So there are considerations. All right, the Beers criteria. You can get online at iTunes or I just realized after doing this talk forever, not iTunes, the App Store. You can go to the App Store and get it, okay? 2015, they're due to do a new update any moment. But I'll show you some of these updates. Drug interactions, renal function, dose adjustments, sliding scale insulin. Did you know that nitrofurantoin, i.e. macrobid, used to be the cutoff, and still if you pull it up in some resources, the cutoff is 60 mLs per minute. You can go all the way down to 30. So if you have a patient that's 45 mLs per minute, 50, macrobid is totally fine. I do it all the time, as long as they just have a bladder infection. Now, if they've got, fever, flank pain, then it's not an appropriate med. Hypnotics, yeah, avoid altogether. Y'all got anybody on Ambien you can't get off? Be honest. It's hard, right? It's hard. Sliding scale insulin. How about this one? PPI is greater than 8 weeks. Come on, man. I laugh every time I see this. I'm like, you people writing guidelines. Have y'all seen a patient ever? Okay. Right? Marketing. What do you know about PPIs? They're prescription and over the counter. Anybody can get them. You can go to the gas station right now. Buc-ee's, get you a big old thing of Prilosec along with your brisket sandwich. Okay. Oh, my mom was awesome, y'all. She died too young. It was really sad. I can tell this story now without crying because she was awesome. But man, she loved her PPI. Man, she loved Mexican food. She's like, and patients will tell you, she's like, Chris, I love this drug. She's like, I can eat whatever I want. And I'm like, yeah, Mom, that's not the point. But anyway, patients, family members, they find out you're in healthcare. They ask you information, but they never follow it, right? They just want to know what you think. They just want to know what the experts say, and then they'll do what they want. Anyway, is it not true? It's like that commercial where the FedEx meeting's going on and the one guy gives a recommendation. They're like, and then some other guy, the big honcho, gives the same exact words. They're like, oh, that's a great idea. Well, wait a minute. No, I said the same thing. Anyway, PPI is going to be 8 weeks. That's a problem. That is a real problem. Other meds here, anticholinergics. Do elderly like anticholinergics? Yeah, which one do they really like? Benadryl. They love Benadryl. Why? Because it works. It does work. I mean, H1, it is an excellent antihistamine, but man, it can cause a lot of blurred vision, urinary retention, you name it. Antipsychotics, increased mortality in the elderly. Black box warning for every antipsychotic. But what do you do? My grandfather, he was a classic case, Alzheimer's patient, would get somewhat combative, with the nursing staff. Like, what do you do for those patients? You can orient them and do things like that, but it's just a difficult situation. How do you keep them at home? Maybe they can't afford a nursing home, and so this is what they do to kind of keep them somewhat tame during the day. Very difficult decision. Dig doses, we'll talk about that later, and spironolactone doses greater than 25. If you exceed 25 a day of spironolactone, you're going to run into hyperkalemia almost every time. Non-benzo hypnotics, NSAIDs in most circumstances, because if you do an NSAID long-term, they're going to probably be on a PPI. Don't use a lot of ketorolac, endomethacin, unless it's really short-term. Gout attacks for Indocin. Y'all still using endomethacin for gout attacks? Yeah? Some still out there. Okay, so this is one of the tables. I'll highlight a couple of things here. First one I want to highlight is amiodarone. So amiodarone, when you give it with Coumadin, it is a guaranteed drug interaction 100% of the time. it will increase the levels of coumadin, sometimes as much as 50 and 75%. So if you're ever going to combine these, you definitely want to do an adjustment. I'll talk about that at the end. All these CNS active drugs, anticholinergic, antidepressant, antipsychotic, all of these are additive. And so I've got a case here in a minute. We'll highlight this really well. So those are a couple I wanted to highlight. Keep in mind, like we talked about, right? Geriatrics have renal function that's depressed. And so a number of drugs are renally cleared. Almost all your DOACs have some degree of renal clearance, especially Xarelto, Lovenox, okay? CNS drugs, Cymbalta, significant renal clearance, gabapentin, Lyrica, okay? And then tramadol, Ultram, that is an opiate, but it does have some significant renal clearance. Your H2 antagonists, of course, ranitidine, you don't have to worry about anymore, but Pepsid. So a lot of these drugs are renally cleared and they can accumulate, causing confusion, especially like a drug like Pepsid. All right, stop criteria. Have y'all seen this one? Yeah, got one? Yes. All right, very good. Yeah, it's got 65, a lot of overlap with the beers, not as comprehensive. It's not my favorite. It focuses primarily on CNS and cardiovascular drugs. It does hound on the musculoskeletal drugs a little bit. I'll show you that. So as you can see, it's very heavy on the CNS drugs. Y'all ever seen SSRIs and hyponatremia? It is very common. It's very common. My primary practice now is inpatient. So we get these admissions pretty frequently because SSRIs, of course, very widely prescribed. And we do see this. Long-term neuroleptics, as we talked about, CNS drugs, long-acting benzos, try to avoid those. Benzos with metabolites like Valium. So those are ones we try to avoid. Found out the other day my dad's been on Xanax for like 10 years. I had no idea. I'm like, Dad, Xanax? He's a pharmacist, retired. So it was a very uncomfortable conversation. That's okay. I thrive in those. It's no big deal to me. But we're good. I was like, we're gonna have to find a way to titrate you off that. You know how that's gonna go. Anybody who's wiped your buttocks as a kid, they're not gonna listen to you probably. We'll see. I love him. He's great. All right. Drugs of adverse fallers, benzos, neuroleptics, long-term opiates, analgesic drugs. Keeping in mind, man, regular opiates constipate people. So trying to use the Miralax, something to prevent. There's nothing sadder than seeing an impaction in an elderly patient. Man, it's really sad. I've seen those. Like we had yesterday, remember my patient on an ACE and an ARB? So just be careful with that, especially these combination products. Sometimes patients know their drug as the brand name. It's got a generic in it, but then they take another generic that's a different, same class. 2 ACE inhibitors. Y'all ever seen that together? I have. ACE and an ARB. So next steps. Man, we have got to do a better job of incorporating this data electronically. Right now, these don't have great specificity. Alert fatigue, right? Oh man, working a pharmacy, the drug interaction software is absolutely terrible. I mean, it flags everything. Duplicate therapy, they're on HCTZ and lisinopril, no kidding, right? So a lot of this is just not helpful. So people get alert fatigue and they miss the really important drug interactions. Now we got a couple studies. The first one here, the deprescribed study. So this is a Canadian cluster trial over 4 years. And this is a really cool study. So what they did is they did 2 simultaneous interventions. One was to the actual prescriber, they sent them evidence-based info to recommend deprescribing one of these or all 4 of these meds if they were on them: antihistamines, glyburide, sedative hypnotics, or NSAIDs. The other intervention done at the same time is they sent the same information to the patient. So the person on the drug got the information and their prescriber got it. They said, let's see what happens. Okay. So here's the results. Not shocking, more females. 75 years was the average age. At 6 months, it cut down about 75, 60, 70% of that beer's medication. So it actually was pretty effective between the two of getting it deprescribed. And this was significant for glyburide, the sedative hypnotics, and the NSAIDs. The only one it wasn't was those first generation antihistamines. They were holding on to them. I don't know what's going on over here. They're having fun. Is that closed? Yeah, okay. Keep in mind, though, when you pull people off sedative hypnotics, about 40% of them had some withdrawal symptoms. Do y'all taper your Ambiens? Yeah? Should. Probably taper them, at least the dose that you can go down to even 5 if you want every other day for a while. Definitely taper. PPIs, you definitely want to taper. PPIs, I used to taper them. Go to once, if they're on twice a day, go to once a day. If they're on once a day, go to every other day for a week or so and then stop. The reason for that is when you shut down the proton pumps, it takes about a day to recover them. But if you shut everything down, they can get some rebound acidity pretty quickly if they've been on it for a long period of time. So in Canada, at least, deprescribing for this, pretty effective, but keep in mind, patients can withdraw pretty good from these sedative hypnotics.